Good morning, everyone. I'm calling to order the December 19th, 2020 meeting of the ACIP. Today we will be discussing the Moderna vaccine, and we will consist of three presentations, a public comment, and then a final vote. So I will turn it back over to Dr. Cohn to continue with the introductions.
Great. Good morning, everyone. This is the Advisory Committee on Immunization Practices meeting. It's day one. Next slide. Welcome to the December 19th and 20th ACIP meeting. This is an emergency meeting. The emergency federal registry notice is available publicly. This is live webcast today, and the final agenda and the webcast link are on the ACIP website. Next slide. Copies of the slides being presented at today's meeting are also available on the ACIP website. You go to the ACIP meetings symbol to get to those slides. Additionally, slides are available through a share file link for ACIP voting liaison and ex officio members. Videos of the live webcast will be posted on the ACIP website approximately 1 week after the meeting, and meeting minutes will also be posted on the ACIP website. A few notes of meeting logistics for those of you, next slide, for those of you who are on the Zoom call. And I know many of you have been on the Zoom call multiple times, so I'll go through these quickly. When Dr. Romero opens the meeting for discussion, please virtually raise your hand. Dr. Romero will take questions first from ACIP voting members and then from ex officio and liaison members. Please disable your video, except for during the discussion and vote, ACIP voting members, and we'll stay on schedule per the meeting agenda as much as possible. Next slide. Our future ACIP meeting dates, at this time, we only have a regularly scheduled ACIP meeting on February 24th and February 25th, 2021. I know you will all be so sad for there to potentially be 2 months between meetings, but we will announce an emergency meeting if there are data available to review that ACIP needs to consider between that time. Next slide. We will have an oral and written public comment for this meeting. We will have oral public comment prior to each vote. So there is a vote scheduled for today and a vote scheduled for tomorrow. So we will have 2 oral public comment sessions. Those individuals who registered for oral public comment, there were many, many more than we have the time to accommodate. So they were selected randomly via a lottery. Those individuals who are not selected and any other individual who would like to make written public comment, please submit that to www.regulation.gov. The docket number is below, and this information is also all available on the CDC website. Next slide. ACIP members agree to forego participation in certain activities related to the vaccines. CDC has issued some limited conflict of interest waivers. Members who conduct clinical trials or serve on data safety monitoring boards may present to the committee members, but they may not vote. They have to abstain from all votes related to discussions of that company. At the beginning of each meeting, ACIP members will state any conflicts of interest. We have 1 vote today that is a vaccine product-specific vote, and we have a couple of ACIP members who will be abstaining from that vote due to their conflicts of interest, or perceived conflicts of interest. Tomorrow, we have a general vote on prioritization, and there will be no members who will abstain from that vote due to perceived or conflict of interest. Next slide. I'm going to hand it back over to you, Dr. Romero, to begin roll call.
Thank you very much, sir. Thank you very much. I will call initially the ACIP members. I will call your name. Please state your institution and conflict of interest. So, if any. So I'll begin. Jose Romero. I'm the Secretary of Health for the state of Arkansas and Professor of Pediatrics at the University of Arkansas for Medical Sciences, and I have no conflicts of interest. Dr. Atmar.
Thank you, Dr. Romero. Robert Atmar. I'm a professor in the section of infectious diseases, Department of Medicine, Baylor College of Medicine. I have a potential conflict in that I participated in NIH-funded COVID-19 vaccine trials, including the Moderna vaccine trial. Over.
Thank you. Good morning and welcome. Dr. Alt.
My name is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas Hospital in Kansas City, Kansas, and I have no conflicts.
Thank you, Dr. Alt. Good morning. Ms. Bata.
Good morning. This is Lynn Bata. I am the immunization clinical consultant with the Minnesota Department of Health, and I have no conflicts. Over.
Good morning and welcome. Dr. Bell.
This is Beth Bell. I'm a clinical professor in the Department of Global Health at the University of Washington, and I have no conflicts.
Thank you. Good morning and welcome. Dr. Bernstein.
Good morning. I am a professor of pediatrics at the Zucker School of Medicine at Hofstra Northwell, and I have no conflicts.
Thank you and good morning. Welcome. Dr. Fry. Dr. Fry, we can hear you.
This is Sharon Fry. Good morning. I'm a professor of internal medicine at St. Louis University, St. Louis, Missouri, and I am conflicted. I am the site principal investigator for the Moderna and Janssen vaccine phase 3 trials.
Thank you. Good morning and welcome. Dr. Hunter.
Paul Hunter, Associate Professor of Family Medicine and Community Health at the University of Wisconsin in Madison. I received a small grant for quality improvement project on pneumococcal vaccines from the Pfizer company.
Thank you. Welcome. Dr. Lee.
Grace Lee, Associate Chief Medical Officer for Stanford Children's Health, Professor of Pediatrics, Stanford University School of Medicine. I have no conflicts.
Thank you and welcome. Ms. McNally.
Good morning, Veronica McNally, President of the Franny Strong Foundation, based in Michigan, and I have no conflicts.
Good morning and welcome. Dr. Paling.
Good morning, Dr. Romero. This is Kathy Paling. I am Professor of Pediatrics and Epidemiology and Prevention at Wake Forest School of Medicine, and I serve as the Director of Pediatric Population Health. I have no conflicts. Thank you.
Thank you and welcome. Dr. Sanchez.
Good morning, Jose. I'm a professor of pediatrics in the divisions of neonatology and pediatric infectious diseases at Nationwide Children's Hospital and The Ohio State University, and I have no conflicts. Thank you.
Thank you. Good morning. Welcome. Dr. Szilagyi.
Good morning. I'm Peter Szilagyi, Professor of Pediatrics and Executive Vice Chair of the Department of Pediatrics at UCLA, and I have no conflicts. Thank you.
Welcome. Good morning. Thank you. Dr. Talbot.
Good morning. I'm Kit Talbot, an Associate Professor at Vanderbilt University Medical Center, and I have no conflicts.
Thank you. Good morning. Welcome. Very good. So welcome all the members. Now I will turn to the ex officio representatives, and I will start with Dr. Messonnier from the Centers for Disease Control and Prevention.
Nancy Messonnier, CDC. Thank you very much.
Good morning. Dr. Fink from the Centers for Medicare and Medicaid Services. Forgive me. Dr. Hance from the Centers of Medicare and Medicaid Services.
Good morning. This is Mary Beth Hance from the Centers for Medicare and Medicaid Services. Thank you.
Thank you. Now, Dr. Fink, Food and Drug Administration.
Good morning, Doran Fink from FDA CBER Office of Vaccines.
Thank you. Dr. Rubin, Health Resources and Services Administration.
Good morning. This is Mary Rubin from the Division of Injury Compensation Programs.
Good morning. Welcome. Dr. Weiser, Indian Health Service, please.
Good morning. This is Tom Weiser from Indian Health Service.
Good morning. Dr. Basil from the National Institutes of Health.
Yeah, good morning. John Bagel from National Institute of Allergy and Infectious Disease, NIH.
Thank you. Good morning. Dr. Beckham from the Office of Infectious Disease, HIV, Aid Policy.
This is David Kim with the Office of Infectious Disease and HIV AIDS Policy, HHS.
Thank you, Dr. Kim. Next, we will go to the liaison representatives, and I will start with the American Academy of Family Physicians, please.
Pamela Rockwell, AAFP, Associate Professor, University of Michigan, present.
Thank you, Dr. Rockwell. American Academy of Pediatrics.
Good morning. This is Yvonne Maldonado, and I'm Professor of Pediatrics, Epidemiology, and Population Health at Stanford University School of Medicine.
Good morning, Dr. Maldonado. Dr. Kimberlin.
David Kimberlin, AAP, Red Book, Liaison.
Morning, Dr. Kimberlin. American Academy of Physicians Assistants.
Good morning. I'm Dr. Sandra De Palma with AAPA, and I'm filling in for Marie-Michelle Leger.
Thank you, Dr. Palma. American College of Health Association, American College Health Association.
This is Tavi Chai with University of North Carolina at Chapel Hill.
Good morning. Welcome, Ms. Chai, or Dr. Chai. American College of Nurse Midwives.
Carol Hayes, present.
Good morning and welcome. American College of Obstetricians and Gynecologists.
This is Dr. Linda Eckert, and I'm a professor of obstetrics and gynecology and global health at the University of Washington, representing ACOG. Thank you.
Thank you and welcome. American College of Physicians.
Dr. Jason Goldman, General Internal Medicine Affiliate Professor at Florida Atlantic University and Nova Southeastern University. Pleasure to be here. Thank you.
Thank you. Welcome. American Geriatric Society.
Ken Schmader for AGS.
Good morning. America's Health Insurance Plans.
Yeah, this is Bob Gluckman, Chief Medical Officer, Providence Health Plans.
Welcome. American Immunization Registry Association.
Good morning, Rebecca Coyle, Executive Director at ERA, and joining me is my colleague Beth Perilla.
Welcome both. American Medical Association.
I'm Dr. Sandra Freihofer, Liaison for the American Medical Association. I'm a practicing general internist in Atlanta and Adjunct Associate Professor of Medicine at Emory.
Thank you. American Nurses Association.
Chad Riddle, representing the ANA.
Good morning. American Osteopathic Association.
Dan Grog, representing AOA, present.
Thank you. American Pharmacists Association.
Good morning. This is Steve Foster.
Welcome. Association of Immunization Managers.
Hi, good morning. This is Molly Howell, North Dakota Department of Health Immunization Manager, representing AIM.
Welcome. Association for Prevention, Teaching, and Research. Association for Prevention, Teaching, and Research. We'll come back to that one. Thank you. Association of State and Territorial Health Officers.
Good morning, Jose. This is Neeraj Shah, the Director of the State of Maine Center for Disease Control, here on behalf of ASTO.
Good morning, welcome. Biotechnology Innovation Organization.
Good morning, Phyllis Arthur for Bio.
Good morning. Council of State and Territorial Epidemiologists.
Dr. Christine Hahn, State Epidemiologist for Idaho, representing CSTE.
Welcome. Canadian National Advisory Committee on Immunization. Canadian National Advisory Committee on Immunization. We'll come back to that. Infectious Diseases Society of America.
Carol Baker, good morning.
Good morning, welcome. International Society for Travel Medicine.
Elizabeth Barnett for ISTM, present.
Good morning. National Association of County and City and Health Officials.
Good morning. It's Matt Zahn, representing HO, present.
Welcome. National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield representing NAPNAP.
Good morning. National Foundation for Infectious Diseases.
Morning, Jose. This is Dr. Bill Schaffner. I'm a professor of preventive medicine and infectious diseases at Vanderbilt and the medical director of the NFID. Thank you.
Thank you and welcome. National Medical Association.
Good morning. This is Pat Whitley Williams, professor of pediatrics, Rutgers Robert Wood Johnson Medical School, representing the National Medical Association. Thank you.
Welcome. Pediatric Infectious Diseases Society.
Good morning. Sean O'Leary, present.
Good morning. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Welcome. Society for Adolescent Health and Medicine.
It's Amy Middleman. Good morning. I'm representing SAM.
Thank you. Welcome. Society for Healthcare Epidemiology of America.
This is Marcy Dries representing SHEA, present.
Good morning and welcome. Let me go back to Association for Prevention, Teaching, and Research.
This is Dr. Paul McKinney, professor, University of Louisville School of Public Health and Information Sciences.
Good morning. And then back to Canadian National Advisory Committee on Immunization. One more time, Canadian National Advisory Committee on Immunization. Okay. Just make sure did I miss any ex officio representatives or liaison representatives? Thank you all very much. Dr. Cohen, I'll turn it back to you. Over.
Great, thank you. Before we get started with our agenda, Dr. Doran Fink from the FDA was going to provide a quick overview of the Thursday VRBPAC meeting and EUA authorization of the vaccine we're talking about today. Dr. Fink?
Hi, good morning. So very quickly, yesterday evening, FDA authorized or issued an emergency use authorization for the Moderna COVID-19 vaccine, which, like the Pfizer vaccine, for which an EUA was issued 1 week ago, is an mRNA and lipid particle vaccine. The Moderna vaccine is authorized for emergency use for active immunization for prevention of COVID-19 caused by the SARS-CoV-2 virus in individuals 18 years of age and older. This emergency use authorization followed a comprehensive FDA review of data submitted in support of the request, as well as a meeting of the Vaccines and Related Biological Products Advisory Committee on Thursday, December 17th, the outcome of which was a nearly unanimous vote in favor of the benefits of the vaccine outweighing its risks for emergency use authorization, with 20 members voting in favor and 1 member abstaining. As you'll hear about in more detail later this afternoon, FDA continues to work very closely with our partners at CDC and also in the United Kingdom to investigate reports of allergic reactions or suspected allergic reactions following use of the Pfizer vaccine in ongoing vaccination campaigns. Some of these reactions have been confirmed to be serious or anaphylactic reactions, and we are working closely with the manufacturer to identify what the cause of these reactions might be. And we will update the public as in a timely manner if we find anything that would cause us to change the conditions of the emergency use authorization, or if we need to provide any additional information to inform the public about the benefits and risks of the vaccine. However, I want to stress that at this time, the totality of the data continue to support vaccinations under the Pfizer EUA without any new restrictions, and we thank the public for remaining vigilant and reporting suspected reactions to the vaccine using the established mechanisms that have been set up. Thank you very much.
Thank you very much, Dr. Fink. Dr. Cohn, any other opening comments?
No, that is it. We can move on to the agenda. Thank you.
Thank you very much. So let's begin with the topic coronavirus disease 2019 with the vaccines. We're going to have an introduction by Dr. Beth Bell, who is the workgroup chair of the ACIP COVID vaccine group. Dr. Bell, good morning, and please go forward.
Good morning. Thank you very much. Could I have the next slide, please? On December 18th, 2020, as you just heard from Dr. Fink, FDA issued an EUA for the Moderna COVID-19 vaccine for the prevention of coronavirus disease 2019, COVID-19, for individuals 18 years of age and older. Next. Today's agenda is listed on this slide. We'll hear from Dr. Jacqueline Miller from Moderna about the mRNA 1273 development program, the grade analysis of the Moderna COVID-19 vaccine by Dr. Julia Gargano, and the evidence to recommendation framework about the vaccine from Dr. Sarah Oliver. There'll be the public comment period, followed by an update on COVID-19 vaccines and anaphylaxis from Dr. Tom Clark from CDC, and clinical considerations for use of the mRNA COVID-19 vaccines by Dr. Sarah Mbei. And then, as you heard, we will have a vote on the Moderna COVID-19 vaccine. Next, one of the benefits of having so many meetings is that my introductions are getting shorter and shorter. And so here is again the list of the workgroup members to whom I remain quite indebted. And similarly, next please, the CDC participants. Thank you. Back to you, Dr. Romero.
Thank you, Dr. Bell. So we'll move on to the first presentation by Dr. Jacqueline Miller on mRNA 1273 development program. Dr. Miller, please.
Thank you, Dr. Romero. Can you hear me okay?
I can.
Okay, good. Thank you so much. And good morning to you all. On behalf of Moderna, it gives me great pleasure to present to you today an overview of the Moderna COVID-19 vaccine and clinical development program. Next slide, please. Next slide, please. So for a brief outline of my presentation, I will go through very briefly the mechanism of action for the mRNA platform and discuss the results of preclinical studies that were conducted to support the clinical development plan. I'll then review the immunogenicity data from phase 1 and 2 trials and spend most of my time talking about the phase 3 safety and efficacy trial. Finally, we'll have a brief review of the vaccine storage and handling, followed by a summary, and then I'm happy to answer any questions you might have. Next slide, please. So talking about the messenger RNA platform. Next slide. Our vaccine is a single sequence of messenger RNA, and that sequence encodes for the spike protein of SARS-CoV-2. That messenger RNA is synthesized from a DNA template, and we then utilize the nucleotides present in messenger RNA, enzymatically polymerize them, and buffer them with FDA-approved buffers.
The mRNA is then protected from degradation by the body's natural lytic enzymes with a lipid nanoparticle. And that lipid nanoparticle serves to help both protect the messenger RNA and also target it via the lymphatics for the draining lymph nodes, where antigen-presenting cells, both dendritic cells and subcapsular macrophages, take up the messenger RNA for further processing and expression. The final drug product is a liquid product, and it is going to be presented in a 10-dose vial. Next slide, please. So as I mentioned, the lipid nanoparticle targets the messenger RNA for delivery to the draining lymph nodes. And once at the antigen-presenting cell, the messenger RNA is released into the cell cytosol, where it's taken up by the ribosomes, whose job is to translate messenger RNA into protein. The spike protein amino acid is then synthesized. It naturally assembles into its trimeric form and is expressed on the cell surface as through normal viral infection. Next slide, please. So now to give a brief overview of the preclinical and early clinical data. Next slide, please. So we conducted a robust non-clinical program in 3 different animal models in order to demonstrate that the vaccine was immunogenic and that there were no safety concerns before taking the vaccine into human clinical development. The vaccine drives a robust SARS-CoV-2 specific antibody and Th1-directed CD4 and CD8 T cell responses in mice, Syrian hamsters, and non-human primates. The non-human primates and mice were also challenged with SARS-CoV-2 after vaccination. And what we saw was even in doses lower than those administered to humans, challenge did not lead to vaccine-associated enhanced respiratory disease. In addition, we recently completed our developmental and reproductive toxicology study, or DART study, and have submitted it to the FDA. No safety concerns were identified. Next slide, please. So overall, we have conducted a full development program, including a phase 1, phase 2, and phase 3 study. The starts of those studies were staggered in order to enable the acquisition of safety data from one phase before moving on to initiate clinical trials in the next phase. We've conducted a phase 1 dose-ranging study, a phase 2 safety and immunogenicity study, and where I'll spend the majority of my time today, the phase 3 safety and efficacy study. Next slide, please. So in terms of the early phase studies, we observed neutralizing antibody titers in all participants following the second dose. The geometric mean titers across age strata are numerically higher than in a pool of convalescent sera. And neutralizing antibodies have persisted for at least 3 months after the second dose and still remain numerically higher than that panel of convalescent sera. We also observed a strong Th1 dominant CD4 positive T cell response. And the results from our early phase studies were consistent with our preclinical results. Next slide, please. So now let's discuss the results of the phase 3 safety and efficacy trial, study 301. Next slide, please. 30,420 subjects were randomized 1-to-1 to receive either 2 doses of 100 micrograms of mRNA 1273 or a saline placebo. Over 15,000 subjects were randomized to each arm, and participants received 2 doses separated by 29 days. Next slide. During the course of the study, there was active COVID surveillance that was performed throughout. Subjects were dosed at day 1 and day 29, and they received phone calls to elicit safety information each week for 1 month after vaccination. They reported their solicited symptoms on an e-diary card, and serious adverse events and medically attended events have been solicited throughout the study. Once subjects exited the vaccination phase, they continued to provide data through weekly e-diary prompts for COVID-19 symptoms and monthly safety calls to make sure safety information had been captured. Next slide, please. So now I'd like to review with you the case definitions for the primary efficacy endpoint, which was symptomatic COVID-19 disease, and the secondary efficacy endpoint of severe disease. So for primary disease, subjects had to have either 2 systemic symptoms, including fever, chills, myalgia, headache, sore throat, or a new smell and taste disorder, or at least 1 respiratory symptom, including cough, shortness of breath, or difficulty breathing, or have clinical or radiographical evidence of pneumonia. And they had to have a positive nasopharyngeal swab for SARS-CoV-2 virus. These cases have been adjudicated by an endpoint adjudication committee, and they had to occur 2 weeks after the second dose. Next slide, please. To be considered in the secondary efficacy endpoint against severe COVID-19 disease, participants had to meet all of the characteristics of the primary case definition and then had to meet at least one of the 4 following additional criteria. Either clinical signs indicative of severe systemic illness, respiratory failure, acute respiratory distress syndrome, or evidence of shock, severe acute organ dysfunction, or admission to an intensive care unit or death. Next slide, please. From the start, it was very important to us that we make sure we included the subjects at highest risk for the severe complications of COVID-19. And so we stratified our enrollment to include at least 25% and up to 50% of participants who were either above 65 years of age or between 18 and 65 years, but also having at least 1 medical condition putting them at increased risk for severe COVID-19. Across the study, we were able to enroll 42% of subjects who fell into the high-risk category. Next slide, please. We also wanted to enroll a diverse and inclusive clinical trial, knowing that communities of color have been disproportionately impacted by COVID-19. We enrolled approximately 10% of African American subjects, 5% Asian American subjects, and 20% of participants self-identified as Hispanic. Next slide, please. In terms of the comorbid conditions, between the 18 to 65 and over 65 year of age group, 23% of participants reported at least one of these conditions, and these are the conditions that were specifically captured. 9% had diabetes, 7% had a BMI over 40, 5% had chronic lung disease, and 5% had significant cardiac disease. Next slide, please. We also specifically sought out individuals who are at increased risk of acquiring COVID-19 due to their occupation or living circumstances. 25% of the participants in our trial were healthcare workers, and the essential workers that are part of Phase 1B of CDC's plan comprised an additional 25% of the trial. Next slide, please. So now I'd like to review our primary efficacy results, and I am focusing on the primary efficacy analysis defined per protocol, which had to include at least 151 cases. Overall, the primary efficacy analysis was performed on 196 cases that met the case definition for the primary endpoint. There were 11 cases in the mRNA 1273 group and 185 cases in the placebo group for an overall vaccine efficacy of 94.1%. The lower limit of the 95% confidence interval was 89.3%, which exceeded the pre-specified statistical criterion of 30%. The p-value was highly significant at less than 0.0001, and the impact of this efficacy can be seen in the difference in incidence rates, which were 3.3 per 1,000 person years in the vaccine group as compared to 56.5 per 1,000 person years in the placebo group. Next slide, please. We also performed various subgroup analyses on demographic characteristics to evaluate the consistency of this efficacy estimate. Across age demographics as well as gender and race, we saw efficacy consistent with our primary efficacy endpoint. Next slide. We also looked at vaccine efficacy against severe disease as a secondary endpoint. There were 30 cases reported at the time of the analysis, all of which had occurred in the placebo group, for an efficacy estimate of 100%. Next slide, please. We also have looked as a secondary efficacy endpoint at the occurrence of symptomatic COVID-19 disease after the first dose. The point estimate of efficacy for cases which occurred 14 days after dose 1 was 95.1%. And you can see that we begin to see a divergence of the cumulative distribution curves as of approximately 10 days after the first dose. Next slide. So now I'd like to show you some additional analyses that were performed to try to further evaluate the accumulation of cases after the first dose. So this slide shows the modified intent to treat population and the accumulation of cases based on the CDC case definition, which is less restrictive than our primary endpoint and requires a single reported symptom on an expanded list of symptoms. There were overall 62 cases in the placebo group as compared to 8 cases in the mRNA 1273 group, with the majority of cases being reported in the first 2 weeks after administration of dose 1 in the 1273 group. These data suggest that protection may begin prior to dose 2, although for full protection, both doses should be given. Next slide. We also have a pre-specified secondary efficacy endpoint for asymptomatic disease. That efficacy endpoint relies on seroconversion to anti-nucleocapsid antibodies. And at the time of our EUA submission, our serology data were not available yet for evaluation. We did obtain pre-vaccination nasal swabs against the SARS-CoV-2 virus, and therefore we summarized the percentage of subjects that had positive nasal swabs prior to administration of dose 1 and dose 2. And we used these data to look further into the question of asymptomatic infection. So this slide presents the subjects who were found to be negative both serologically and by nasal swab prior to entry in the study at dose 1, who had a positive nasopharyngeal swab prior to dose 2. There were 38 positive swabs in the placebo group as compared to 14 positive swabs in the mRNA 1273 group, representing nearly a 2/3 reduction in positive swabs, again suggesting that there may be efficacy against asymptomatic infection. Further data will follow. Next slide, please. So now I'd like to transition to speak about the safety analysis we performed after a median duration of 9 weeks of safety follow-up. Next slide, please. So let's speak about the solicited adverse reactions. These were reactions that subjects were specifically queried about on an electronic diary card. We captured this information in all 30,000 subjects enrolled. Next slide. So this slide shows you on the top the mRNA 1273 group, and at the bottom the placebo group, including grade 1, 2, and 3 solicited local reactions. The reactions that were captured included injection site pain, erythema, and swelling, and then swelling or tenderness in the draining lymph node adjacent to the vaccinated arm. Overall, the most commonly reported symptom was injection site pain, with a more frequent reporting in subjects who were 18 years of age to 65 years of age as compared to those over 65. Next slide. This slide presents the reported injection site reactions after dose 2. And there was a more frequent reporting in the mRNA 1273 group after the second dose as compared to after the first dose. The majority of symptoms are still mild to moderate in severity, and they had a median duration of 2 to 3 days. Next slide. So now we'll transition to the solicited general symptoms that were captured, and these data are after the first injection for the mRNA 1273 group and placebo group stratified by age. Again, the older adults tended to report less frequently than younger adults. And interestingly, in our placebo group, close to 30% of subjects reported in the 18 to 65 group fatigue and headache. Again, the majority of symptoms are mild to moderate in severity. Next slide. As for the local solicited symptoms, we saw an increase in the reported rate and severity of reactions after the second dose. And again, we saw more frequent reporting in younger versus the older age cohort. Over 96% of subjects were compliant with the 2-dose vaccination schedule. And as for the local solicited symptoms, the general solicited symptoms had a median duration of 3 days or less. Next slide. I'd also like to present to you the solicited local reactions by patients who were found to be baseline positive for SARS-CoV-2. So subjects were excluded if they reported a known history of COVID-19 disease. We did perform baseline screening for serology against anti-nucleocapsid antibodies to indicate past infection, and nasopharyngeal swabs for SARS-CoV-2 infection to indicate current infection. And those subjects were enrolled into the trial. We wondered whether subjects would report an increased rate of adverse reactions if they had previously been exposed to the spike protein, and we did not observe that to be the case. The reported rates were actually observed to be lower in initially seropositive subjects. Next slide, please. So now I'll transition to speaking about the unsolicited adverse events. And these were adverse events that were captured by subjects through a memory aid and interviewed by site staff through those weekly phone calls for the month after vaccination and then monthly thereafter. Next slide, please. So overall, the rates of adverse events were comparable between the treatment groups, including medically attended adverse events and serious adverse events. Next slide, please. I'd like to show you on this slide the rates of medically attended adverse events between the two treatment groups with mRNA 1273 in blue and placebo in gray. What you see on the x-axis of the slide are the system organ classes, or the groups of types of solicited symptoms reported throughout the study. And overall, we saw comparable rates between the two groups. The excess in infections and infestations in the placebo group was primarily due to COVID-19. Next slide. We observed a similar pattern for the rates of serious adverse events that were reported throughout the study. Again, rates were comparable between the two groups. Next slide. We had deaths reported throughout the study. The only cause of death that was reported in more than one subject per group was myocardial infarction, and the review of the causes of death did not lead to any safety concerns. All of the deaths have been assessed as not related by the investigator. Next slide, please. So because of the recent discussions of anaphylaxis following vaccination with another messenger RNA vaccine, I've included a description of the cases we observed in Study 301. Importantly, we did not exclude participants if they had a general history of anaphylaxis, urticaria, or other significant hypersensitivities, although subjects were excluded if they had a known allergy or anaphylactic reaction to a component of the vaccine. At the time of our EUA submission, we had 2 anaphylactic reactions that had been reported as unsolicited AEs. One was in a placebo group, occurring 10 days after the first dose. This was in a subject who received radiocontrast dye. One occurred in a subject who received mRNA 1273, which occurred 63 days after the second dose. And that subject had reported a history of allergy to shellfish. Last night, we had another anaphylaxis reaction in the placebo group reported, and that case is still under investigation. We also wanted to look at the reactions that could be classified as anaphylaxis within the 48 hours after vaccination. And we did this through something called a standardized measure query. So it's a standardized way to look at a clinical database and pull out the terms which have been mapped to potential anaphylaxis. In the mRNA 1273 group, there were 4 cases that were identified. None of them met the Brighton collaboration definition for anaphylaxis. All of them were grade 1 to 2 in severity. None of them were serious and all recovered. Next slide, please. And I wanted to spend just a moment talking about the safety surveillance that will continue as we transition to continuing the conduct of our phase 3 study and conducting safety surveillance for the individuals who will be vaccinated with mRNA 1273 moving forward. We recognize that vaccination of pediatric patients will be important. We have an ongoing study in adolescent subjects who are 12 to 18 years of age, which started earlier this month. And we are discussing with the NIH and the ICCRD the study design for a pediatric clinical trial in younger subjects, ranging from 6 months of age to 12 years of age. We are about to initiate a collaboration with the National Cancer Institute to evaluate the safety and immunogenicity of our vaccine in patients with cancer. And we are also going to be actively participating in the post-authorization surveillance that will be conducted by FDA as well as CDC. In addition, Moderna will be launching its own post-authorization safety study in a large insurance database to investigate reported adverse events after vaccination. We are developing a global pregnancy registry, and now that our developmental and reproductive toxicology study results are available, and we have a positive efficacy and reassuring safety signal in non-pregnant adults, we're ready to consider conduct of clinical trials in pregnant women. And then finally, we will be conducting a post-authorization effectiveness study with Kaiser Southern California, where we will look at the effectiveness of mRNA 1273 in the real-world use setting. And we will continue to collaborate with NIH, FDA, and the CDC, as well as other government agencies in order to further investigate the efficacy and the safety of the vaccine. Next slide. So one final word about the vaccine storage and handling. Next slide. So the mRNA 1273 vaccine is shipped at -20 degrees Celsius. The minimal shipment order is 100 doses. So the vaccine is packaged in a 10-dose vial. and there are 10 vials that come in that carton. In the refrigerator, it can be stored from 2 to 8 degrees Celsius for 30 days, and then when the vaccine is thawed for use, it can be held at room temperature for up to 12 hours. Once the multiple dose vial has been punctured, it needs to be used within 6 hours, and that is because the vaccine contains no preservatives. It's a liquid formulation, so no further dilution is required. Next slide, please. So in summary, mRNA-1273 was observed to have 94.1% efficacy in our primary analysis based on 196 cases. The primary efficacy hypothesis was met with a lower limit of the 95% confidence interval of 89.3%, exceeding the pre-specified 30% margin. The vaccine was observed to reduce the incidence of severe COVID-19 disease, with 30 cases observed in the placebo group at the time of the analysis. Other secondary sensitivity and subgroup analyses support the primary efficacy analysis results. An acceptable tolerability profile has been observed, with over 96% of subjects receiving their second dose. More solicited adverse events were reported after the second dose, with the majority of events mild to moderate in severity and short-lived in duration. The safety profile is overall clinically acceptable, and therefore mRNA-1273 has the potential to address the SARS-CoV-2 pandemic and has been authorized for emergency use. Next slide, please. In closing, I just wanted to say a heartfelt thank you. So I have been privileged to be able to present these data on Thursday and today, but I am representing a cast of thousands that have contributed to the generation of these results. Both my colleagues at Moderna, as well as the collaborators who you see on this slide, deserve our sincere thanks. But most especially, I would like to extend that thanks to our investigators, their site staff, and the study participants, without whose tireless efforts we would not have data available to discuss today. Thank you, and I'll be happy to answer any questions you might have.
Thank you, Dr. Miller, for that very informative presentation. It's now open for discussion and questions by the voting members. And I saw Dr. Alt's hand up first. So Dr. Alt, please.
Thank you, Dr. Miller. You had a color starting at about slide 30, red color for grade 4 reactions, but I didn't see the color used. Were there any grade 4 reactions in those slides? I didn't notice them as they flashed by.
Yes, there were a few grade 4 reactions, but they occur at a percentage low enough that it's difficult to see on the slide. The grade 4 reactions were only on the solicited general symptoms, and they were in the area of fever, arthralgia, and myalgia, and headache.
Thank you.
Sure.
Thank you. Dr. Fry.
Thank you, Dr. Romero, and thank you for a great presentation. I have two questions. One, I'd like to know if there were any autoimmune cases or any unusual pneumonias or other presentations that were discussed by safety monitors or safety committee in relation to a possible hyperinflammatory response or something that would be suggestive of a Th2 biased response within the first 28 days after vaccination. Thank you.
Yes, thank you, Dr. Fry. So maybe I'll start the answer to your question by saying that we did look at how many patients reported autoimmune conditions by medical history when entering the trial, and there were approximately 1,200 subjects in each group. We did look at autoimmune conditions overall and did not see imbalances between the groups. So, for example, there was one case of rheumatoid arthritis that occurred in the 1273 group, but there was one case of polymyalgia rheumatica that occurred in the placebo group. There was one SAE that was assessed by the investigator as related regarding a cryptogenic organizing pneumonia. That case was assessed by the investigator as potentially vaccine related. However, that subject had a number of samples for SARS-CoV-2, and one was not ever identified as positive. So the cause of the cryptogenic organizing pneumonia still remains unknown.
Thank you. Dr. Paling, please go forward.
I second.
Oh, sorry, Dr. Fry, forgive me. I thought you were finished. Please, Dr. Fry, continue.
Thank you, Dr. Romero. My second question is, were there any unusual skin rashes or any other kinds of skin conditions seen post-vaccination within the, I would say, 28 days? And just to clarify the first question, my question was, I know if the person wasn't found positive for COVID, was really in relationship to vaccine, not COVID disease per se. Thank you.
Yes, so your question about the injection site reactions. So as with the local injection site reactions, there were some an excess of cases of injection site rash and urticaria reported in the mRNA 1273 group. There was a small subset of subjects who reported some delayed injection site reactions. So these are reactions that occurred beyond the 8-day reporting period. There were approximately 90 that happened after dose 1 and fewer that happened after dose 2. Only 2 subjects had reactions after both dose 1 and dose 2. This was actually a topic that was discussed at the DSMB. It was also referred to a dermatopathologist, so these rashes tended to be erythematous with a central turgidity. And the assessment of these rashes was that they were likely to be due to a localized immune reaction in the dermis and not a systemic reaction such as Stevens-Johnson. The subjects actually were well during the event and were able to engage in normal activities, and the events have resolved.
Dr. Fry, do you have any other questions?
No, thank you.
Thank you very much. Bless you, whoever sneezed. We'll move on to Dr. Paling, please.
Hi, Dr. Miller, thank you for this great presentation. And as you know, we're all paying attention to the reactions. I have wanted to ask you about pregnancy. How many people were enrolled and became pregnancy, and what were the outcomes of those pregnancies to date?
Yes, thank you for that question. So we've had 13 pregnancies reported throughout the trial. And I should mention that upon enrollment, because we did not yet have the results of the developmental and reproductive tox study, we did do pregnancy tests prior to each vaccination, and we asked women to continue contraception and refrain from becoming pregnant until 3 months after their second vaccination. Of those 13 pregnancies, 7 have occurred in the placebo group and 6 have occurred in the mRNA 1273 group. We have outcomes for 3 of the pregnancies. So one of the placebo subjects has been lost to follow-up. One of the placebo subjects underwent spontaneous abortion, and the third placebo subject underwent elective termination. The remaining pregnancies continue, and we will follow them for full outcome.
Okay. The next I wanted to ask you about Bell's palsy. Could you tell us about the experience with Bell's palsy and when it occurred after vaccine or placebo?
Yes, so we have had 4 cases of Bell's palsy reported thus far in the clinical trial. 3 of them have occurred in the mRNA 1273 group. One has occurred in the placebo group, and those cases have occurred between 15 and 32 days after vaccination. The cases are all resolved or resolving at this point in time.
All right, thank you.
Thank you. Dr. Goldman, I see you are there, but we're going to run through the voting members first. Don't take your hand down. I will come back to you. So I'm going to, let me ask 2 questions, if I may, Dr. Miller. The first is, can you tell us what are the constituents of the excipient of your vaccine? And the second question is the lipid nanoparticles. What are the lipid constituents of those? And are there any similarities between your vaccine and that of Pfizer? Over.
Yes, thank you for that question, Dr. Romero. And to answer your question, our Chief Scientific Officer, Dr. Melissa Moore, is joining me today. So I'm going to let Dr. Moore answer that question. Dr. Moore?
Thank you, Dr. Miller. Can you hear me?
Yes, hear you well.
We can.
Okay, thank you. So can you just repeat the question, please?
Yes, so 2 questions. Can you please tell us what the constituents in your excipient of the vaccine is? And second of all, the lipid constituents of the nanoparticles, and are there any similarities to the Pfizer product?
Mm-hmm. So the excipients in our product are sucrose and 2 pharmaceutical buffers, tris and acetate. Those are the only excipients. We use a different buffer system than Pfizer. I believe they use phosphate buffered saline. In terms of the lipid nanoparticles, our lipid nanoparticles contain 4 constituents. One is an RNA binding lipid that is a proprietary lipid developed by Moderna that breaks down rapidly in the body. One is DSPC, which is a natural component of human lung surfactant. Another is a little bit of cholesterol. And then we also use a polyethylene glycol lipid, or a PEG lipid, to keep the lipid nanoparticles from fusing in the vial. So that's all that's in there in addition to the RNA. The differences in our product from Pfizer are we use different proprietary RNA binding lipids.
Thank you for that answer, those answers. Thank you very much. Dr. Bernstein, please.
Thank you, Dr. Romero, and thank you, Dr. Miller, for a clear presentation of the Moderna data. I had a couple questions. One is, what mitigation recommendations were made to study participants?
So Dr. Bernstein, thanks for your question. Could you please give me just a little bit more context, mitigation with respect to what?
I'm on a call with the CDC and I have to answer questions. So.
Oh, Dr. Moore, I think you're not on mute. I'm sorry, Dr. Bernstein. Could I please ask you just to mitigate against which risk?
Well, were they encouraged to wear masks, for example?
Yes. Definitely. The study investigators had a discussion at the investigator meeting around the importance of these kinds of measures. But to your point, the reason why we enroll people at highest risk for disease is because we know that we need to be able to capture cases in order to assess vaccine efficacy. So the subjects in the trial were at increased risk, either based on their geography, their occupation, their medical comorbidities, or their age, but they were encouraged to keep themselves safe.
Thank you. And then if you could go to slide 21, please. So looking at the bottom row where it has race and ethnicity, it certainly looked encouraging that communities of color benefited from the vaccine. But I was surprised in the placebo group that there were twice as many cases in the non-Hispanic whites than in the communities of color. Given the epidemiology and that communities of color are more likely to get COVID-19. I was wondering if you had any thoughts about that.
So I think when we look overall at the study was designed to assess the symptomatic COVID-19 in the entire population. And we've done these subgroup analyses because they're really critically important to understand if the efficacy is consistent. But nonetheless, the more finely we split these different case groups, of course, the smaller the sample size becomes. We expect that as we continue surveillance, we will start to see increased rates in all of the groups, or at least increased reported numbers of cases. And so we're going to continue to evaluate our efficacy over time. But what we can say from this subgroup analysis, for which the study was not sufficiently powered, was that the observed efficacy in the various groups was highly consistent with the primary efficacy analysis.
Okay, that was a surprising finding in the placebo group, but the power may be a factor. And then the third question I had relating to the potential allergic manifestations. I noticed in their phase 1 trial, there were 3 withdrawals for hives and a macular papular rash and a sore throat in the phase 1 trial. And then you mentioned about the dermal hypersensitivity at the injection site, which also included pruritus. And then I also noticed that under the serious AEs reported by at least 2 subjects, there was swelling of the face. Can you elaborate a little bit about that?
Sure. So I think a previous questioner had asked about the delayed hypersensitivity reactions at the injection site. So I'll focus on the facial swelling. So these were 3 cases that occurred in women who had previously had injections of hyaluronic acid, so as a plastic surgery procedure, and facial swelling was noted after vaccination. And it resolved after treatment with Benadryl and other supportive therapies.
Thank you.
Thank you very much. Dr. Atmar?
Thank you, Dr. Romero, and thank you for a very clear presentation. I have a few questions. One is to follow up on the skin. Other than the facial swelling and the localized reactions, were there any other generalized skin reactions observed?
So there were some reports of rash throughout the study in the unsolicited AEs. The rashes that really were imbalanced between the groups were the injection site rashes that were noted in the week after vaccination or soon after vaccination. We did actually run one of those standardized measure queries, not just on subjects 48 hours after vaccination, but overall. And we did not observe large imbalances between the groups. So there were few reactions reported, and overall they were balanced between vaccine and placebo.
Thank you. In terms of looking at a history of anaphylaxis, how many participants had a history of anaphylaxis in your cohort?
So in terms of the medical history to anaphylaxis, I don't have that answer at my fingertips. What I can say is that in the overall category of anaphylaxis and allergic events and autoimmune events, the subjects were well balanced in their medical history. So there were subjects who were enrolled. And I should mention that for that chronic lung disease that we were specifically seeking, moderate to severe asthma was a condition that was specifically highlighted in the protocol to be of interest. And we did not see a imbalance between the two groups of events in those categories from medical history.
Thank you. My final question relates to trying to figure out how long protection from the after vaccination may last. So we have information now 2 to 3 months after completion of the vaccine series. Can you give us a little more information about what your plans are for examining duration of protection and the need for a booster?
Absolutely. So we anticipate in the next few weeks to have 6-month antibody persistence data from the phase 1 study with which we collaborated on with NIH. In both the phase 2 and the phase 3 study, we have planned antibody persistence time points at 3 months, 6 months, and 12 months after vaccination. And of course, that follow-up will continue for 2 years after vaccination in the phase 3 study. We are right now speaking about conducting 6-month boosters in the phase 2 study. The reason for that, we will be able to vaccinate a naive cohort and then look at the cohort that received the 100 microgram dose and see if they are able to boost to the vaccine. We're also intending to look at antibody kinetics approximately 1 week after vaccination in order to ensure that we see an immune memory response. So we should be able to provide more data about persistence and boosting in the coming months.
Thank you.
Dr. Sanchez, please go forward.
Hi, thanks, Hossein. Thank you for the really a very clear and very exciting data that you just presented. I have a few questions. Very importantly about the and the pregnancy issue, you've already answered. But are you looking at women who with lactation and breastfeeding, and in terms of any effects on the neonate and infant? And I know you have a pregnancy. You're establishing a pregnancy cohort, or but I was wondering if you have any data or if there's anything that you're going to be looking in terms of like women breastfeeding and the infant outcomes.
Yes, thank you for that question. And so we've heard very, very clearly from our stakeholders that the safety and immunogenicity of the vaccine in pregnant women is a topic of clear interest. Now that we have observed the positive efficacy signal and the reassuring safety profile in non-pregnant adults, and we've completed the animal studies of developmental and reproductive toxicology, we're ready to begin considering the clinical study design in pregnant women and their children. And as you mentioned, I think there are many important considerations, including breast milk and follow-up in the infants. I will say from the DART study, we did observe a robust immune response in the mothers. These were in rats. And there was also transplacental transfer of antibodies to the pups. So we would definitely be interested in looking into the antibody transfer to young neonates as a method of protection.
And no, thank you. And how about the placental? Was there any abnormalities or anything seen differently in the placenta of the immunized animals versus those who presumably received placebo?
So to answer your question specifically about placental observations, I would like to ask our toxicology expert, Dr. Rodrigo Laureano, to answer your question. So Dr. Laureano, are you on the line? Dr. Laureano could not make it this morning. So what I will say is in the report that I read, there were no malformations or abnormalities observed in the dams or pups. So I can't speak specifically to the placenta, but it certainly was not highlighted as a finding of the report.
Thank you. Another question that I had is with respect to the skin reactions, the allergic or the hypersensitivity possibility of hypersensitivity reactions. How about treatment? Did you look at how many actually required treatment within 15 to 30 minutes as is being proposed with either Benadryl or epinephrine or anything?
Yes, we did. And so I should mention that the injection site reactions that we're discussing actually had their onset a bit later, some of them within the 7-day duration period, some of them outside of it. But in terms of the reactions that occurred within the first 30 minutes after vaccination, that was the population on which we conducted that standardized measure query, for anaphylaxis. So we saw symptoms that were sometimes reported with other allergic reactions like tachypnea or dizziness. But all of those reactions, there were 4 of them. They were grade 1 to 2 in severity. They did, in some cases, receive Benadryl or prednisone, and all of them resolved. There was no epinephrine administered.
No hospitalization required.
No hospitalization. They were all non-serious.
And then my final question is, I find it interesting. So the primary efficacy was in those who were seronegative and had not had a previous SARS-CoV-2 infection.
Correct.
And so, but there were some individuals who were enrolled, or at least who were enrolled, who actually had a past history of having at least were seropositive. From thinking one of your tables that I see here. I see that there were like 341 in the vaccine group and 334 in the placebo group, so they were similar. And I presume all of those individuals had been asymptomatic, nothing consistent with a COVID-19 infection.
I believe there was one individual who developed a COVID-19 infection after participating in the trial. This was a subject that was actually randomized to the 1273 group that received placebo, and unfortunately developed a second infection while on trial. But other than that, there was an overall efficacy analysis performed. I don't have it at my fingertips right now because it was a relatively small proportion of the group, but it was not inconsistent with the overall efficacy of analysis.
So so you had some individuals who had been seropositive at the time of enrollment, and they still developed another infection, at least by PCR?
Yes, indeed. There was at least one subject that I'm aware of, and I'd have to go back and look to see if there were others.
Okay.
But we did do an analysis on the full analysis set. So considering everybody at the time of randomization, not considering whether or not they got their vaccination according to their assigned treatment group, and it included the entire population, so not just the 2% that were seropositive, but seropositive and seronegative. And the overall efficacy was 93.6%.
Because I think, one of the questions keeps coming up is among individuals who had a a COVID-19 infection previously, and what is the risk subsequently of having another possible significant infection, and the vaccination in that group. So I think that data are very important.
Yes, thank you. We would agree.
Thank you.
Thank you. Dr. Talbot, please.
Thank you so much. And you can tell we're incredibly excited by the number of questions that keep coming. Very excited to have another vaccine that works this well. My question is in regards to the Bell's palsy cases. Do you have an average age or an age range of those cases? It's common for adults to have Bell's palsy, but it'd be very helpful to see if that shifted the age of Bell's palsy lower. Thank you.
Yeah, thank you for that question. That is a very interesting question, and I do not have the age range at my fingertips, but the team is trying to look it up for me. So I'll be happy to answer it when they're able to provide that information to me. Oh, wait, I have it. It's age 30 to age 72.
Wow. Since they're so quickly have been able to do that, would the majority over or under 50?
So one of the cases was age 30. One of the cases was age 67. One of the cases was age 72. And I believe, yeah, and then the final case was age 52.
Thank you. Incredibly helpful.
Dr. Bernstein, I see your hand up again.
Yeah, sorry. I just wanted to, I apologize if you answered this already. I heard about pediatric cases, pediatric studies going down to 6 months. But I was wondering, did you mention when you'll have data for 16 and 17-year-olds or 12 through 17-year-olds?
Yes, I didn't mention it, so thank you for asking the question. Our clinical trial in 12 to 18-year-olds began on December 9th, and the last time I checked, we had 6 subjects enrolled. The full study is expected to be completed in 2021, but we need to have discussions about how much data would be sufficient to potentially evaluate the potential to lower the age indication for the vaccine, understanding that vaccinating our children will be very important to getting them back to school and protecting our educators. But we have not yet had the opportunity to speak to the agency about this, so I won't be able to comment further today.
Thank you. I agree that this would be important, especially as Pfizer's is currently down to 16 as well.
Dr. Bata, I'm sorry, Dr. Bernstein, are you done?
Yes, thank you.
Thank you. Dr. Bata, your hand is up. Did you have another question?
Yes, I have 2 questions. And thank you, Dr. Miller, for this information. It's been very, very helpful, and it's very exciting. One of the questions that I had was related to your modified intent to treat, and if you could talk a little bit about any stray from the schedule of the 28 days between the 2 doses. Any of these individuals have delayed doses, and is there an impact on that?
Yeah, so we allowed per protocol subjects to come in between day 26, so 3 days before day 29, out to day 36, so 7 days after day 29. And then likely due to disruptions from COVID-19, we actually did find that there were a relatively significant number of individuals who came in as early as 1 week prior, so 3 weeks after dose 1, and as much as 2 weeks after dose 1, so 6 weeks out from the final dose. And that 3-week span actually forms the basis of the per protocol analysis. We've not analyzed specifically by when cases may have occurred based on when people may have been vaccinated. So I don't have those data to share today.
Okay, thank you. And then my other question is, are there any details about the rates of adverse events by race and ethnicity?
There are some details, and if I could ask the CDC to please flash slide 55 in the backup. Overall, we saw that in this subgroup analysis that the estimates of efficacy were consistent with the primary analysis, but as was earlier pointed out, the sample size is small. That's not exactly the right number, so apologies for that. I thought it was slides 55 and 56 in the backup. Maybe go to slide 56, please. There we go. So these are the case splits per race as observed in the trial.
Okay, so this is related to efficacy. Do you have any information about adverse events following vaccination?
We do, and we did not observe that one racial group had a particularly higher reported incidence of adverse events than other racial groups. And the pattern of reporting was consistent, so increased reporting after dose 2, and similar adverse events were reported more frequently.
Okay, thank you.
Thank you, Ms. Bata. So our liaison members have been waiting very patiently, and so I'm going to turn to them now and look down the list. And Dr. Goldman, thank you very much for being so patient.
No, thank you, Dr. Romero. First, excellent presentation, very informative. Thank you for all of your hard work. My question relates to the storage and handling in a practical approach. We're seeing in the community, at least with the Pfizer vaccine, that there is some overfill of the multi-dose vial, which potentially people are saying will give 1 to 2 more doses. I'm wondering if you have anticipated this with your vials. Will there be any overfill? What would be the recommendations if there is overfill of a vial and potential extra doses as it relates to administration?
So thanks for that question. And in a moment, I'm going to ask Dr. Nadim Altaras, who is our head of CMC, to answer. I will say that with every liquid vaccine, there's always overfill because there's always extra material that is in the vial, on the sides of the vial, in the stopper, in the needle of the syringe. But Dr. Altaras can talk to the studies that we've done to look at whether additional doses could be drawn. Dr. Altaras, are you there?
Yes. Can you hear me?
Yes, hear you well.
Great. Thank you. So yes, as Dr. Miller described, USP1 provides that each container of injectable product is filled with a volume that slightly exceeds the content indicated in the labeling. For our product, the intended labeling has been 10 doses, and the excess volume is really meant to be sufficient to permit withdrawal and administration of that labeled volumes, in our case, which was 10 again. We did conduct several studies to define the most appropriate fill volume for our product to allow these 10 doses to be withdrawn when a needle and syringe is used to withdraw each dose. We do not anticipate that most users will be able to withdraw more than 10 doses using typical syringes and needles. Occasionally, there might be some very skilled individuals. If they withdraw the doses very carefully, they might be able to withdraw an 11th dose, but we don't anticipate that to be common, given the fill volume that we have optimized. Did that answer your question?
Well, I'm wondering, if I may, if there is a skilled individual and they do happen to fill a quantity sufficient for an 11th dose, is it recommended to utilize that or to waste it?
In our EUA fact sheet, as it's been published by FDA, there is no claim of how many doses one individual can actually remove. The label after the Pfizer discussion has been updated to not refer to the number of doses FDA has advised previously that all doses could be utilized that's been withdrawable from a vaccine vial.
Yeah, this is Dr. Cohen. I just want to let everyone know that this we will talk about this for everyone tomorrow as well.
Thank you, Dr. Cohen. Any more discussion on that question by Dr. Moolman? Okay. Dr. Freihofer, please.
Thank you. So an excellent presentation. I have 4 little tiny questions. The first is refers to slide 21. Your vaccine efficacy of 94.1% overall is absolutely fabulous. But if you look at the older patients, they were in the 80s. So except for those over 70. So wondered if you had any feedback about that. The next question is about the timing between getting injected, the facial swelling associated with dermal fillers. And my question is about the timing between which when patients receive the filler injections and the vaccine injections. My third question is you said that patients that had previously had COVID seem to react less to the vaccine. Any theoretical reason for that? And the fourth question is you mentioned in the DART study that there was transplancental transfer of antibody. Did the mRNA cross the placenta?
Dr. Romero, we may not have time to address all 4 questions. Do you want to have a couple of those questions answered and we can follow up in writing, or?
Sure. Let's start with the question about the DART study.
Perfect. Thanks.
If we could do the DART study and the filler question, that would be great.
Thank you.
Thank you.
Okay, great. I'm going to start with the DART study, and then for the dermal filler question, I'm going to ask our head of pharmacovigilance, Dr. David Martin, to respond to your question because he may have more of the details. I'm not aware that in the DART study we specifically looked for the mRNA to cross the placenta. The reason for that is that mRNA is very naturally broken down, and our data in investigating our platform suggests that after 2 days, the mRNA is completely degraded. So it's not something that we expect to hang around very often after vaccination. Then, Dr. Martin, do you want to speak to the dermal fillers, please?
Sure. Yes, there were 4 adverse events reported in the mRNA 1273 participants, and the filler injections were received between 13 days and more than 6 months prior, with one actually of unknown duration prior, as far as the relationship of the dermal filler. And all resolved except one grade 1 AE, so low level, was, as of the last we heard, was resolving.
So, Dr. Freihofer, does that answer your question?
Yes, thank you. And thank you.
Thank you very much. So just a quick word to all those that are about to ask questions. I'm going to ask you to please limit yourself to one question. We are over our time limit this time, but I don't want to suspend a discussion at this moment. So Dr. Rockwell, please.
Thank you. Dr. Miller, excellent presentation. Quick question. Were any of your study participants in having comorbidities with cancer and possibly treatment for cancer such as chemotherapy? And if so, do you have any data?
We can't hear the answer if it's being given.
Apologies. I had put myself on mute, so thank you for that reminder. So subjects in this trial were excluded if they had a known cause of immunosuppression. That said, there were a handful of subjects that were enrolled who had baseline stable conditions such as chronic lymphocytic leukemia, but to my knowledge, none of them were actively on chemotherapy. This is the reason for engaging in the NCI collaborative study in order to assess the vaccine in those subjects.
Thank you very much.
Thank you. There's a lot of hands up here, so I'm just trying to make sure I didn't get something. Dr. Stinchfield, please.
Yes, thank you. Patsy Stinchfield from NAPNAP. I had an ethical question and a practical question, but I guess I will limit it to the practical question. In the event that, which sometimes happens, there's a mishap at the time of injection and some of the product is lost, what are your recommendations for repeating that injection, doing it at the same site, different site? Do you have advice on that?
Yeah, so what I can say is that the vaccine has been studied in a 2-dose schedule, and we haven't studied other than in 15 subjects in the NIH study doses higher than 100 micrograms. So in the absence of that data, I would suggest that I'll defer that question to the CDC and perhaps discussion later this afternoon.
Thank you. Okay, Dr. Sanchez?
Yes, thank you. I had another question with respect to the asymptomatic carriage that you looked at, and that there was a suggestion, because I mean, that's really critical in trying to limit the spread of this virus. Do you know if the ones who were positive, the nasopharynx was positive before dose 2 from just routine screening? I believe there were 14 you mentioned. Was that associated with any decreased antibody responses? Have you correlated that with other markers that could help us determine which of these individuals may actually be carriers or chronic?
That's a very interesting question. We have not yet received our immunogenicity data and have not fully analyzed our immunogenicity data, but that's certainly a very interesting additional analysis for us to conduct.
Thank you.
Thank you. Dr. Paling.
Dr. Miller, I wanted to ask you about appendicitis in the vaccine and the placebo groups.
Yes. What about appendicitis? I'm sorry, I don't think I understand the question.
I wanted to understand the number of cases of appendicitis that was seen in the 2 groups and any differences observed. And when did they occur?
So for that question, I am going to see if Dr. Martin is available to answer. Dr. Martin? Yeah, it looks like these are not numbers we have at our fingertips. Can we follow up with you later about that question?
Yes, I'm sorry. We'll have to follow up later.
That would be, this is Jose. That would be acceptable. Thank you. Okay. I want to make sure that I'm not missing anyone again. Dr. Stinchfield, your hand is up. Is it? You have another question for us?
No, thank you.
Thank you very much. Okay, Dr. Whitney Williams, please. Whitley Williams.
Thank you, Dr. Romero. Again, thank you for the presentation. I had a question about the AE of occurrence of a rash It was not on the table, so it was not one of the most common or more common. I raised the concern because sometimes rashes may not be that evident on people of darker skin color. So I just urge, as more doses are dispensed, that there be close attention paid to that symptom and that finding. I also applaud you for taking a look at the occurrence of SAEs and any adverse event. I think to stay on top of this, and should there be any should there be any disproportionate occurrence of any adverse event, that that be brought to light, particularly as it affects people of color. I think we are. The message is getting out, and more people of color from the community are expressing an interest in getting the vaccine. And I think one way to stay on the right path is to make sure that we are monitoring for adverse events. Obviously, 10% better than 1% enrollment in the trials, but the numbers are still small, and so we may not see some of those events occur until there are 10,000, 20,000 people of color immunized. So again, thank you for the presentation of the data.
Thank you, Dr. Whitley-Williams, and we completely agree with you that this is a place to start and a platform on which we can improve. I'm thrilled to hear that people from communities of color and the African American communities are interested in being vaccinated. And if I can indulge the last question, I have some information about the cases of appendicitis. So these were the serious adverse events that were reported as appendicitis in the trial. There were 2 cases in the vaccine group and 3 cases in the placebo group.
Thank you for that follow-up. Dr. Shaw.
Thanks, Dr. Romero. This is Nirav Shah from the state of Maine on behalf of ASTO. I believe I'm asking a question for which at this time there is perhaps not a clear answer, but there are reports from public health officials and agencies in the UK and South Africa, as well as a Canadian province, of a new strain that has emerged. Is there any sense, or at least a theoretical approach, for how we might evaluate this vaccine's efficacy against the possibility of a new strain, and how the vaccine may behave in such situations?
Yeah, thanks for that question. And thanks for highlighting that this is a constantly changing pandemic that's kept, I think, everyone on their toes throughout the entire process. So we have been looking into this question. We have evaluated the ability of sera to neutralize some of those mutant strains. And to give you some more detail about those experiments, I'm going to invite Dr. Melissa Moore, the Chief Scientific Officer, to come back online. Dr. Moore?
Thank you, Dr. Miller. Thank you, Dr. Miller. Yes, we are actively looking at all of the mutant strains that are emerging. And we have sera that from our animals that we have, animal studies that we have immunized, so both rodents and non-human primates, that we are testing against the emerging strains. And so far, we have found that all of the emerging strains that we've tested, the animal sera neutralize them. We also will be testing for neutralization using our human sera that we're collecting as part of our trial. So we are keeping an eye on this very, very much. And finally, any breakthrough cases in our clinical trial, we're going to be doing deep sequencing to look at what the mutation status of those viruses are.
Thank you.
Thank you very much. So we're going to have to end. Dr. Howell, I'm going to give you the last question, please.
Hi, Molly Howell representing AIM. I was just wondering, on slide 25, looking at the asymptomatic infections, do you have cycle thresholds on those individuals, and was there any difference between the vaccine versus the placebo group?
In terms of the cycle thresholds, I am going to see if, yeah, I think we're going to have to come back and provide you that information. I don't have it at my fingertips. Apologies.
So we're going to end here. Dr. Miller and your colleagues, thank you very much for taking our questions and for your very in-depth answers and for seeking the answers that we for the questions we asked. So I'm going to ask Dr. Cohn for some guidance here. Dr. Cohn, do you want us to take can we afford to take a 15-minute break, or should we make it shorter?
We can take a 15-minute break and come back at 1 p.m.
That sounds fine. So as mentioned by Dr. Cohn, we will be back at 1 p.m. Thank you all very much for this very robust discussion and questions. Thank you.